Today, Sensible Money's founder and CEO, Dana Onspa, is going to walk us through how to plan for healthcare costs in retirement. You see a couple more faces on the screen. So Dana is joined by two insurance specialists today, Mike Smith and Stefan Chernesky. They will be adding their insurance expertise to our discussion. As many of you know, Dana is one of the nation's leading authorities on retirement and decumulation planning. And this year, in 2025, Sensible Money was named by USA Today as one of the best financial advisory firms in the country. My name is Amy Shepard. I'm one of the partners and financial planners here at Sensible Money. And most of our team is based in Scottsdale, Arizona. Dana and I are. We also have, teammates spread throughout the country, and we work seamlessly with those coworkers and with clients, across the country as well, using some of the same technology that we're going to be using in today's webinar. So you will see a question box. Most of you already typed in there. If you have questions along the way, please feel free to ask questions. We will do our best to try to answer them as we go. And if not, we can answer any remaining questions. There will be plenty of time at the end of today's session. So with that, I will let Dana get started. Take it away, Dana.
Thank you so much, Amy and Mike, Stefan. Thank you so much for joining us. I think this is our third year in a row doing this webinar together, and having your expertise here to answer some of the very specific questions that we get is absolutely invaluable, as it is in our daily practice when we reach out to you and ask for your help. So we really appreciate you taking time to join us today. As many of you regular attendees know, I have to start with disclosures. And so we may use case studies or talk about specific examples. Of course, we always encourage you to check with your own advisors to make sure that anything we say is applicable to your specific situation. Nothing we're talking about is intended to be a solicitation to buy or sell securities. It is educational in nature. So with that out of the way, let's talk about what we are going to talk about today. We're going to break healthcare in retirement into three phases. We've got the pre-65 phase. So those who want to retire early and aren't eligible for Medicare yet. We've got the post-65 phase, so now you become eligible for Medicare and you'll need to have a health plan that pairs with Medicare, so we'll be talking about that and how you make those decisions and what kind of costs to expect. And we'll be talking about your later years, and I describe it as your later years. You will hear me talk about what I call the 4 phases of retirement: the pre-go phase, the 10 years before retirement, the go-go phase in early retirement, and then the slow-go and no-go phase. And I was in a client meeting yesterday, and our client, Amy, was with me, asked, what's no-go? I don't want to be there. I don't want that phase. And that's what we think of as, those later years, you slow down. And it doesn't mean that you're necessarily in a nursing home, although it could entail that. I have a set of clients we've worked with for over 20 years. They're 89 years old. They are still fully, at home, self-sufficient, independent, but their no-go years would just be starting. They're not going out or traveling as much. It's just more challenging and difficult. And they're really starting to realize they need those plans for assisted living or potential nursing home care one day. And so that's what I think of those as of those later years. And you need to be planning for those years in this earlier phase, because by the time you get there, we have seen that cognitive decline can set in. And even if it's not obvious decline, the decision making can be more challenging. You can get more overwhelmed by the types of decisions that you have to make. So it's critically important to plan for those later years while you are in these earlier phases. Now, for each of these phases, we're going to break the content down a little bit differently. If you've seen this webinar in the past, we do like to update it every year. We're going to talk about what your options are in each phase, what your average or expected costs might be, and then we'll dive into some of the details that apply to each phase. So let's get started and talk about the pre-65 phase for people lucky enough to retire before age 65. What are your healthcare options? And Mike, I want to hand this off to you and have you walk us through. I know this is an area you work in a lot. what are the options that people have if they want to retire before they're eligible for Medicare?
Absolutely. So, pretty common. A lot of people still have an offer of employer-sponsored health insurance. As we know, that can actually take you past 65. But as Dana's saying, if you're lucky enough to be able to hang it all up and enjoy your retirement prior to that phase, you are going to be given a COBRA offer. That's just an extension of your employer-sponsored plan that can go for up to 18 months, 36 under some circumstances there for various people. I would make a note there that I always encourage people to look at the efficacy of that offer. I've seen a lot of people just say, oh, it's expensive and kind of throw the letter away and not even pay it attention. But definitely want to keep an eye on that. So that's the first thing I would really look at. If you're in a boat where maybe you didn't have employer coverage, or perhaps the COBRA offer is a little bit unaffordable, we can always explore something through the Affordable Care Act, also known as the marketplace or exchange plans. Everywhere in the country, they pretty much either have a federally based or state-based exchange, but similar idea where you have tax credits that offset premiums that you would have to pay for your health insurance. There's also a good bit of wiggle room there with some off-exchange options. So there's some plans now that allow you to be a fractional owner of a company and obtain group health insurance. There's various short-term plans depending on how long you have to go to get to Medicare and things like that. So that's always something we want to look at too. And then, there are also alternative plans that are available. Those are going to be more like your faith-based type of health plans or health sharing plans. Those are options. I always say look at them. You want to pay attention to the details of those because those aren't actually insurance products. They don't quite have the same level of guarantee. So you just want to be aware of exactly what it is that you're signing on there for those.
And Mike, out of those options, I know what we see most often, but is there one of these options that you see people using more often than others?
Yes, I would say that, generally, depending on how you're retiring and what your income looks like in retirement, especially, sometimes that Cobra offer may make a lot of sense. And then if you're at all eligible for, tax credits that help you save on premiums, definitely want to look at a marketplace plan or an Affordable Care Act type plan there. Again, where we can be a little bit more creative if there's need for perhaps, some network issues that maybe work better with commercial insurance. Maybe that off exchange example might work. But I would say it really does boil down to whether you qualify for those tax credits or not, can be kind of a pretty guiding principle as to whether that's going to work for you. And again, we just look at it from a dollars and cents standpoint for where you're going to find efficiency in your healthcare.
Yeah, that makes sense. And that's exactly what we see. We see that the majority of people don't have employment with that offers an employer covered option. And so they're perhaps, using Cobra for the first 18 months and then switching over to an Affordable Care Act plan. And so I was just curious if what we see is also in line with what you see. Now, when we look at the estimated costs, I think this is what you're referring to as terms of efficacy is if somebody does have the option of using a COBRA plan, then they would be comparing the monthly cost of that with one of these options. Does that sound right?
Yes, absolutely. So, fundamentally, when you're comparing that to these metal level plans, and again, from kind of left to right, this is very well laid out. Your bronze level plans are going to be lower in premium, but broadly spoken, have potentially a higher threshold for where insurance start paying, meaning that you have higher copays, you may have higher out-of-pocket costs, but the premium is lower. And then as you kind of shift right on the chart through silver, gold, and platinum, those out of pocket expenses are going to dwindle. I always encourage people here, again, in comparison to Cobra and what we're looking at here, what do I actually get for my premium dollar? Because sometimes, even if you have a higher deductible or a higher max out of pocket, but maybe you're a low utilization person, meaning that you don't frequent the doctor, you don't have chronic conditions you're managing, things like that, maybe something more on the bronze side of the coin may make more sense for you because again, the only guarantee there is if we have higher coverage through like a gold or a platinum plan, more premium. But if you want to be a good steward of those dollars and you have a plan to cover for a catastrophe, it's never a bad idea to look at maybe a higher deductible option for sure.
Yeah, and I think with some of the changes that came out with the new tax bill now, is that all the bronze plans can be paired with a health savings account, so you can fund an HSA tax-free. Is that correct?
Yes, that's actually a new development. I'm pretty excited about that. Absolutely, bronze plans. This doesn't really necessarily always apply to the early retiree, but catastrophic plans as well have that option in there. And then, there are HSA qualified plans, so high deductible health plans within the bronze and the silver level. But starting next year, just any plan in that class of bronze is going to qualify you to make those contributions. So a pretty helpful tool to continue to save for your later retirement years.
And as we were talking about this, I just realized we didn't really set the framework here that what we are talking about with bronze, silver, gold, and platinum is specifically plans offered through the healthcare.gov or exchange plans. And so I forgot to just label that or qualify that we're specifically talking about here's how they describe those plans, and the government basically specifies what benefits have to be offered with each plan, a minimum. Is that correct?
Yes, no, that is, and really what I tell everybody is, it's I don't want to say misleading, but it can be a little bit confusing because if you're going to shop for something, it's like, well, I'd rather have the gold plan, wouldn't I? That's just a little bit better than the bronze level plan. And what I encourage everybody to consider when you're looking at these options is fundamentally, even within one insurance carrier, because you are still buying a plan through an insurance company. This is not a government health insurance, it's just a tax credit from the government. So when you're looking at these types of plans, a lot of times the networks and everything like that, the doctors that are in them are going to be the same, regardless of the metal level. It's just your price point is affected by, hey, do I have a higher or a lower deductible or lower copays? So that's where, there's a lot of merit to really considering which one of these plans does make the best sense for you on a coverage level.
That makes sense. And just to clarify for our audience, these estimates that we're putting here are going to vary by where you're located. These are average costs in 2025 for somebody that's age 60. If you were younger, these premiums would likely be lower, but if you were closer to 65, they may be a little higher. Is that correct, Mike?
Yep, unfortunately, as we get closer to Medicare age, those premiums do tend to climb up just a little bit, but it's a pretty graduated ladder there. So, it's all pretty manageable. But yeah, as a snapshot working all over the country, very accurate kind of numbers that you see before you there.
Yeah. And in a few minutes, we'll talk about how we incorporate these pricing estimates into a financial plan to make sure that you can cover them. I know for some people, paying $1,000 a month for health insurance pre-65 may seem like a lot, especially if you've been with an employer where they are covering most of those costs. But oftentimes, if it's only for a few years to get you to that age 65, it is manageable, and there are ways to make sure that it can be covered.
Absolutely. And I would say you're going to talk about this here in a little bit, but remember, these are kind of more the retail costs of the plans. If your income is now lower due to retirement, you probably qualify for some sort of tax subsidies that will offset this premium sometimes by a pretty drastic amount, making it, kind of a clear front runner for an option to get you to Medicare for sure.
Yeah, and I know that's what we're talking about next. And so we have this healthcare premium tax credit that we've alluded to a few times already. And it has had some certain provisions from 21 to 25 that have been very favorable and allowed a lot of people to qualify for these credits. But starting in 2026, it is reverting back to what the rules were pre-2021. And so it's a little bit more of what we call a cliff subsidy now, meaning when your income crosses a certain threshold, all of a sudden you're eligible for no credits. And just a quick overview, it is how do they determine income? Well, it's modified adjusted gross income. So you take your adjusted gross income, which you can find on your tax return, and then there's some add back items, a tax exempt foreign income, the non-taxable part of Social Security, and any tax exempt interest, such as from municipal bonds. So you have to add those back to get to modified adjusted gross income. And if your income exceeds the federal poverty levels by over 400%, so if you cross these thresholds, depending on your household size, then you would not be eligible for a credit at all starting in 2026. And so I want to take a look at specifically how that has changed. What the government does is it basically says, we're going to create a benchmark based on the second lowest priced silver plan. And you're going to have to pay a percentage of that benchmark. And so here in 2025, we have the percentages that you would be required to pay. And then in 2026, here's how that changes. And so just giving you an example, let's say in 2026, your benchmark plan was going to be $20,000 a year, and you would be required to pay 9.96% of that, or only about $1,992, about $2,000 a year. You would get a credit that covers the rest, which is pretty amazing. But once your income crossed that 400% threshold, you pay all. So that's a drastic difference. This is how you understand it to be changing too, Mike?
Yeah, similar. So one of the good things, and again, it is inconvenient that this sort of subsidy cliff is now back on the table. But if you really look at sometimes when you're pushing up even against, above 400% of the federal poverty limit, and you have that 8.5% kind of cap, it was right around there, a typical tax credit for somebody in that boat might only be $20 or $30 a month just to kind of pay for the overall premium. So in short, if you need to lean on one of these plans going into retirement and you happen to be at the higher income spectrum, it's still not going to be totally different from where it was before. You're just not getting that little minuscule bit of help on the tail end, and it's pretty easy to even cross over into that. So, the message that I would say about this change is you want to be aware of it, you want to plan for it, but at the same time, don't let the talking point of, oh, this cliff is back on the table, and just avoid even exploring these plans as an option for that reason.
Excellent point, and offering a bit of hope. I appreciate
Yeah.
it. And to that point, there's often some planning. So here we're looking at, these poverty level limits will be indexed to inflation as they are each year, but there's planning that can be done where your modified adjusted gross income can be kept below these levels so that you do qualify for higher credits. And we had to do that much more aggressively pre-2021. The last few years, we've still done that kind of planning, but it meant if we went over by a little bit, it wasn't just boom, no credits. So now that planning is going to become even more critical. The other change I understand is that what happened before is you provide an estimate when you fill out your healthcare.gov application of what your modified adjusted gross income is. And I'm telling you right now, most people have no idea. They think, it's their cash flow or it's the amount of pension they get. And so you have to have a actual estimate as if you did your tax return. And so, we project all of that out and can say, no, here's what you should use in that estimate. Well, from 21 to 2025, there was actually this provision that said if you estimated wrong and you were going to owe money back, they capped the amount that you would owe back. So you weren't going to get a big surprise. But that cap is also gone, and it means that getting these estimates correct is going to be more important than ever, or you could just be in for a much bigger surprise when you file if you crossed over going, oh my gosh, there's no cap anymore, I owe it all back.
No, that's absolutely correct. So I say everybody, really work with your professionals here. I know just everybody at Sensible Money does a really good job of working with accountants and everybody to make sure that these numbers are accurate. Because yes, going into next year, we do not want surprises or surprise income that we didn't account for. Getting a nasty tax surprise at the end of the year for sure.
Yep. We don't like nasty cash flow surprises in retirement.
No, no. And I, just on that point, I would say that, if you're close to where maybe you're maxing out subsidies or barely qualifying, the difference is a handful of dollars a month. So just be aware of that. And I can actually show you what is your worst case scenario if you all of a sudden hopefully come into a large windfall or something like that. What's the most I would have to pay back? So that's a known quantity when you're doing that planning.
And I love that because, as you know, we all always like to plan on the worst case for retirement and make sure we've got cash flow covered for those scenarios. And then anything better than that, well, that becomes extra, and that just brings peace of mind as you're going through that transition.
Absolutely.
Moving on, the other thing we like to talk about in this pre-age 65 is health savings accounts. And we talked a little bit about how now many of the bronze plans, I think all of the bronze plans, allow you to fund an HSA. And so just some basics. To contribute to a health savings account, you have to have a high deductible plan that is designated as HSA eligible. It is what we sometimes refer to as triple tax-free. Contributions are tax deductible going in. Their growth is tax-free, and then they're tax-free coming out if they are used for qualified medical expenses. You can fund them up until you enroll in Medicare. We're going to talk about that and the details of that in our next section. And pre-65, you can use them for all kinds of things that are considered qualified out of pocket. And Stefan, you can also use them for qualified long-term care premiums. Tell us a little bit about that.
Yeah, absolutely. So HSAs are a great planning tool. I know everyone on this call today is a big fan of them as well too, but a creative way that you can pay for what is called a tax qualified long-term care policy is to use your HSA. Now, there are certain rules you have to follow and certain amounts that can qualify for you to be able to pay for your HSA. But once again, this does provide a useful tool for folks that are interested in implementing some sort of insurance for long-term care needs, which we will dive into a little bit further later. It does provide them another funding source where they can get some tax advantages to pay for some rather important coverage depending on their circumstances in the future. So a great option for people for looking for ways to pay for long-term care.
Yeah, and what I like about that is so many people fund their HSA, but then they use it. And I know a lot of the plans give us these great debit cards, and we can use it for our co-pays or some of our dental expenses. But because it's one of the few ways you can grow money tax-free, our preferential way of using these is to fund them and let them grow, or use them to cover something like long-term care that we're going to need later, a way of pre-funding something that we can use later. And so having a use strategy for your HSA outside of just, oh, I'm going to use it to cover my copays right now, can be really smart. If people haven't come up with that, sometimes what we're doing, because an HSA is a very beneficial account to leave to your spouse, but it's not a tax preferred way to pass along assets to anyone else. We'll often say, well, around 70, let's come up with a plan to cover these. And they can also be used to cover long-term care expenses directly if you didn't have the insurance ahead of time. Is that also true, Stefan?
That would be accurate as well too.
Okay,
Yep.
great.
Hey,
And
hey
then,
Dana, real quick,
yeah,
are you able to hit hide at the bottom of your screen? Do you see that little thing that says app go to is sharing your screen and there's a blue stop sharing and then a hide button? It's covering just the little bit of content on the slides.
there we
There we go.
go.
Perfect. Thank you.
Thank you. um, then Mike, one of the questions that we get all the time, you can cover COBRA premiums. So if you, are wondering, oh my gosh, I've lost my job, I'm not 65 yet, how am I going to cover this cost? But I believe you cannot use your HSA to cover the healthcare.gov or exchange premiums. Is that also true?
That is correct. Yeah, you cannot use it for any insurance premiums that basically come from a company. So COBRA continuation coverage is eligible, as you said. Also, post 65, you can use it to pay your government premiums. So your Part B, any Part D, things like that. So that can be helpful there too, especially if you have a couple of years of elevated premiums, which we'll talk about later.
Yeah, and that's one of our distribution plans. If we're looking at someone that has been successful at accumulating funds in HSAs, then we might say, okay, when your Medicare Part B premiums kick in, and when they get larger later, once your required distributions start, maybe this HSA can be a really good asset that can cover those Medicare Part B premiums, but it cannot cover the premiums for the Medigap or Advantage plans.
No, unfortunately not. And actually, it can for the Advantage because it's technically a part of it, but a lot of times that's a low or no premium plan itself.
Okay.
Yeah.
They make it so easy, don't they?
Yeah, it's all confusing.
Yep. One of the things that we see is missed funding opportunities for people that have a family plan. So they might be funding their own HSA, but not also funding it for a spouse. And we see missed opportunities for catch-ups. And so your basic limit in 2025 is 4,300 a person. That's going to 4,400 in 2026. But you can put in an extra $1,000 each if you're both over 55. So that would actually make the max in 2025 $10,550. Now, there's this weird rule that you can put most of the family contribution into one plan, but the catch-up has to go into the name of an account in that spouse's actual name. And so they almost eliminated that rule with the new tax bill, but at the end they pulled it back out. And so we're left with this, weird rule that says you could put the bulk of this $10,550 into one HSA. But if you wanted to max out the $1,000 for your spouse, they would have to have their own HSA account to get that last little bit in there. So as we said, they make it very easy for us. Shifting gears into that post 65. So if you've planned out your expenses for, the pre 65, if you're going to retire early, or maybe you're working to 65 or later, and now you're going to have to navigate this transition onto Medicare. So Mike, walk us through all these various parts of Medicare. What are we looking at here?
Sure, absolutely. So, it's so confusing. It's like alphabet soup sometimes looking at this. It's like, well, I have A, I have B, I have C, I have D, I have plan Gs and Fs, and, what does it all mean? But, I tell everybody, simply put, there really are fundamentally two choices in how you use your Medicare, just your government benefits. So as this slide says, you have Part A for your hospital insurance. Very simply put, that's really kind of think of that like hotel hospital. It's room and board at the hospital. It's not really necessarily the treatment there. It's just you're staying in the hospital, right? So provided that you work 10 years or 40 quarters, as most folks that have, had jobs since they were teenagers here in this country, they've fully funded that. There's potentially no premium for that. Sometimes that can be a premium that somebody pays if they don't have the work history. Part B is going to be the strong arm of your Medicare, I tell everybody. That's your medical coverage. And really simply put, and I believe making this as simple as possible because it's not necessarily simple, is that's basically 80-20 co-insurance from the government. So basically what that means is Medicare itself is writing a blank check for 80% of all of your, medical needs. And then with nothing behind it, you're on the hook for the 20%. So I like the blank check from the government. I don't like the blank check for somebody with nothing behind it, right? So the other part here is Part D. Now that can take a couple of different forms. If you just have original Medicare and you choose to enroll in a Part D plan, you would be doing that to get, basically your prescription benefits. Think of that like your routine maintenance medications that you pick up at the pharmacy counter. That's really what that's designed to cover. Now that can also go into a Part C plan, which is also on the right. And when you enroll in a Medicare Advantage plan or a Part C, you kind of bundle all the benefits of A, B, and D, and you assign it to an insurance company, and that manages your entire care. So that's the difference there. But you would never have A, B, D, and C. It's either A, B, D plus a supplement or C. And I think we're going to talk about that in more detail on one of the following slides.
Yeah, we will get into that. Before we go there, Stefan, one of the things that we hear a lot is people don't need long-term care coverage because Medicare will cover that. I know that's a myth. Tell us why.
Yeah, absolutely. So there there is that false hope that Medicare could cover yourself for long-term care, but it's in a very small subsection for people that it would be applicable to. And the way that Medicare can cover is that if you're in a hospital and it's warranted that you are discharged directly to a nursing care facility, right? And in that example there, the first 20 days would be covered. And then after those 20 days, from day 21 to 100, there is a coinsurance applicable there. And then after those 100 days, you are on your own. So at that point in time, if you had no plan in place, you did not have any long-term care insurance, you would have to pay for any care that you needed out of pocket. There are other routes that you can go in terms of Medicaid, but hopefully everyone on this call here today is planning for situations to avoid potentially going down that route of Medicaid. But as far as Medicare goes, very limited circumstances and only the first 100 days with a copay attached to that.
Yeah, and we have seen many people shocked, when they realize, oh, these costs aren't necessarily covered by Medicare. And I'm glad you brought up that distinction of Medicaid. So Medicaid, the rules to qualify for basically government subsidized care uh, depend on the state you live in, and you generally have to spend down almost all your assets and have very little income to qualify. And so when someone is faced with a situation where they don't have enough assets or income to cover their care, it's often working with the state or working with an elder care attorney to say, okay, how can we get you qualified for the Medicaid system? Generally, the types of people listening to this webinar, that's not going to apply to them, but I think it is good to know because we all know people who may need that kind of assistance one day. Mike, when we were talking, actually, I'll back up a second. As you mentioned, you can have A, B, and D, or you have C, and that's typically, framed in terms of you're either choosing an Advantage plan or a Medigap. And I have a little note down here. We will use the term Medigap or Medicare supplement policy interchangeably. They mean the same thing, but walk us through the differences and how this works.
They do, yeah. So again, just to keep this simply put, when I'm working with people, I believe in, just explaining it in this manner. And I tell everybody, fundamentally, you have a fork in the road decision that you make with how you use your Medicare benefits. And one way of using them is, of course, to use an Advantage plan, which we're all about to see all the commercials. They drive me crazy too every fall. It's just part of the year, right? But when you're using one of those systems, it's important to note you are not using a secondary insurance. The Advantage plan actually encompasses all of your Medicare coverage. So Medicare itself assigns your Medicare benefits to an insurance company there, and you are in what's called a managed care plan. It's perhaps an HMO or a PPO type plan. And again, there's no right or wrong to any of this. It's just what works for you. But when you're looking at an Advantage plan, I think one of the big determining factors for which one of these is going to make more sense is potentially with an Advantage plan, it's low to no premium. So you still have to pay your government Part B premiums. But on that side of the fence, you may not have an additional cost for being enrolled in the plan. The trade-off there is you're going to have co-pays, max out-of-pockets, potentially deductibles that could be a little bit higher. But again, you're in a managed care plan with a network, things like that. If you are using what I would call the Medigap route, or the Medicare supplement route, as some people call it, you're choosing to retain your original Medicare benefits. So when you go to the doctor, rather than when we were on an Advantage plan, you show them one card that kind of gets it all done. They're going to want to see your actual red, white, and blue Medicare card. That's your primary insurance. And then the Medigap plan actually fills that void of the blank check of 20% that you were going to write. The risk is now shifted to an insurance carrier so that that's not something that you contend with. Really, anybody born after 1955, the Medicare Part B deductible is $257. If you use a Plan G supplement, they're all the same. Basically, your max out of pocket is $257. The big con of that system is, in contrast to using an Advantage plan, is you will have additional premium dollars to pay for the Medigap plan, as well as potentially the Part D plan that provides your prescription benefits at the pharmacy.
So, when you're talking about costs, I pulled this off of the internet, it's a T-Row price estimate. And so it was just estimating the out-of-pocket cost for the Medicare Advantage versus the traditional Medicare with the Medigap. Now, in addition, we would have to add the premiums for Part B under both of these columns, and the premiums for the Medigap policy itself under this column. I'm seeing those premiums for Medigap running about $300 a month. Does that seem about right?
Again, it's very varied based on where you live. So, the East Coast, it tends to be a little bit more expensive. Where you have maybe more retirees, somewhere like Florida can be a little bit more expensive. But yeah, it's somewhere, I kind of tell everybody at current, somewhere in about the $180 range to even slightly above 300, depending on where you're at. So also a good sense of, hey, if I'm planning on moving somewhere else, potentially what do my premiums look like there for a Medicare supplement, right? But yeah, that's probably a safe number to guess, especially if you're a few years away from retirement.
And so if I had to add, let's say an extra 3,600 in premiums here and zero here, because I don't have any premiums, and then my Medicare Part B is going to be the same under either plan, I would look at this and go, well, I'm going to pay 3,600 in premiums, and I'm going to pay, potentially slightly higher out-of-pocket costs. Why would I choose the Medigap plan? And I know historically that there's been a lot of improvements in the Advantage plan, but we've often tell people, if you can afford it, go with the Medigap plans. So looking at this, why would one choose the more expensive option?
So there's a couple of factors to this. Sometimes it does just become a math problem. So if somebody has a chronic condition and maybe the max out of pocket on an Advantage plan, not citing a specific one, is maybe more in line with $3,000, and they know they may potentially hit that every year, it's a sunk cost, right? And now if you're going to frequent the doctor and it keeps your monthly, utilization costs, as I call it, low, that can actually be a financial leverage where you're actually coming out ahead even with paying the additional premium. To me, when I'm helping people make the decision, between which one's going to work better for them, I would really boil it down to, I believe fundamentally the thing that you have to ask yourself is how much you value freedom of choice. Because again, you do have a lot of choice in Advantage plans, but you are using a network. You are beholden to use doctors within that network for preferred pricing. Sometimes if it's a PPO, you can go out of network, but it's potentially for a much higher share of cost. So there is that, and you are in a managed care, plan. So you're going to have some authorization requirements for certain procedures, things like that. If you're choosing to go the other route and use original Medicare with a Medigap or a Medicare supplement, by retaining your traditional or original Medicare, as you hear it called, you are basically just signing on to use anybody in the country that takes Medicare. There's no real prior authorization. There's codes for everything, and it's fee-for-service medicine, meaning that your doctor and you decide that there's a course of treatment that Medicare approves. It will just go through very smoothly. They'll bill Medicare, and it's not a lot of roadblocks to getting treatment. So it's the flavor of how it works for you too. I kind of have started calling this there's no free lunch idea, right? It's like, If you're willing to pay a little bit more in premium to secure that side of coverage, I tell everybody if you value freedom at that rate, it's not going to be a bad choice for you. And again, if you just say, hey, I go to the doctor once a year and I think I want to save the premium and that side looks better to me, that's not a bad choice either. You just have to understand the differences at a deep level and exactly what you're signing on for.
And I think, that freedom of choice is one of the reasons why we've often said if you have two homes, if you like to, winter in Arizona where we are, and summer elsewhere, which I would advise, it's been miserable here lately. But, you would choose this Medicare, original Medicare plus a supplement plan because that freedom of choice to go back and forth between any providers is going to be far more useful when you're between different locations. Is that accurate?
Yeah, and even on the Advantage side now, there are some plans that have more national networks, so it's a little bit, better in that regard. But still, yes, I mean, dollar for dollar, pound for pound, traditional Medicare is accepted. The question I tell everybody, how does it feel if you just have to ask two questions when you call a doctor's office? Do you take Medicare, and when can I come? That's basically what that is on that side. So yes, it is a little bit smoother, if you kind of
Yep.
move around the country a lot and you don't want to have to think about networks. 100%. Yeah, it's just a little bit easier.
And then the other issue I think comes to what we call guarantee issue, right? If you
Mhm.
are in a Medicare plan, you can switch once a year. If you're in an Advantage plan, though, and then later you want to switch to Medicare, is it that you have to go through underwriting?
Yeah, so basically, when you enroll really in Medicare Part B for the first time, so that's incredibly common now that people work past 65, and I think we're going to talk a little bit about that. But long story short, when you're making the choice of how you want to use your Medicare coverage to its fullest the first time, you kind of have a couple of buffers to determine what's going to work best for you. So the first time you enroll in Part B, you can choose any Medigap policy or a supplement that's available in your area, no questions asked, for the first 6 months that you're on Medicare Part B. After that, you can shop any month you want and try to find a more competitive rate. The barrier to entry is going to be just some health questions, a little bit of medical underwriting. Oftentimes it's just yes, no's, maybe I list some prescriptions. But again, if you're a relatively healthy individual, you'll be able to move, pretty fluidly there. If you are on an Advantage plan, let's say you're really torn and you're like, I think it works for me now, you actually get what's called a 12-month trial right. And that's not only the first time you start Medicare, but the first time you truly start an Advantage plan. So if it doesn't work for you anytime within that first 12 months, if you're new to Medicare, you get a no questions asked. Even if you're month 7 through 12, you can transition over to a Medicare supplement with no health questions being asked because that's a right that you have. If you happen to have a supplement, you move to an Advantage plan maybe to try to save some premium. You get into it and you figure out, I don't really want to be here. You will be able to move right back to the same insurer that you had and retain your old policy, no questions asked. But the key is it is a 12-month period. Don't have great success for 12 months, get into month 13, 14, have something change, and then call me and say, hey, I need that other coverage because we've now exhausted that window.
Okay, so it's only after that 12-month window, then it would require underwriting to get back into the Medicare side of things. And is it possible you could be denied?
Well, so you can always return to Medicare A and B. The real kind of
Right.
worry that I have for folks, I'll say, is it's hard sometimes to get a supplement if you're shopping it because, hey, I want that type of coverage, I want that freedom, but I do have some hiccups in my health. The Medicare supplement insurer could say, this is not an insurable risk that we're comfortable with. We're not going to issue coverage for you.
Yeah. Okay. Yeah. So it's a matter of risk, as so many things in retirement planning are risk return trade-offs.
Yep.
What kind of risks do I want to retain? If I had a significant health event, it's possible that this would be the less costly option. But if I have no major health events, it's likely this is going to be the less costly option. And then you're weighing all of that out. If something develops and now I can't go back this way, I would be basically stuck on this side. Is that an accurate way of saying it?
You could potentially be stuck there just, and again, I urge somebody to have either an advantage plan in place or a supplement just to contain your cost. That
Yep,
again
yep,
is the really big worry that I have. But yes, I mean, you could, there's some other kind of more extreme situations where if you're in an advantage plan, you're given options to get a supplement, but they're not really in your control all the time. So we can't bank on them. But yeah, it's just something you want to be aware of. And again, this is largely a math problem. We kind of look at your needs. You know, like you said, a
yep.
chronic condition might be something that you really want to make sure you have a supplement because your overall cost is lower, even with the additional premium. But we just weigh that out, look at a best case, worst case kind of scenario, kind of assess your comfort level with the idea. And then ultimately, you tell me where you want to go with it, right? And
Yeah.
we've made a good choice at that point.
What I like is, this advantage side has improved so much. And so, I can hear how much it has changed since it first came out, where, there seemed to be a lot more risk involved, and they've really changed some of that, and it sounds a lot less risky than it used to be, and like a really good option for a lot of people.
Yeah, they have improved quite a bit. They've addressed a lot of concerns. So I think it is worth looking at every time. Just again, it's another option. And ultimately,
Yep,
you're the one that makes the choice. It's your choice.
yep. And the last thing I just wanted to touch on, because we see these out-of-pocket costs running down this vertical side, is, well, what determines this? And they've said basically you would expect to pay the higher end of out-of-pocket costs if you had chronic conditions like hypertension, high blood pressure, high cholesterol, arthritis, osteoarthritis, heart disease, diabetes, cancer, depression, asthma, chronic kidney disease. So those were kind of the 12 conditions that, as you had more of those, you would expect to of course pay more out-of-pocket costs, just more co-pays, more visits, those kinds of things. And we'll take a look at what we do in our plans, and how we incorporate all these assumptions. Before we do that, the last thing we've touched on is these monthly B and D premiums. And so just a quick note here, this base Part B premium is what everybody pays when they enroll in Part B on a monthly basis if their modified adjusted gross income are below these threshold limits. And these are 2025 limits that we're looking at here, and they are indexed to inflation. But as your modified adjusted gross income goes up, there is a look back. They look back at your tax return 2 years prior. And so the estimate is about 5% of the population, probably a much larger percentage of our clients that we work with are subject to these B and D premiums. And on the D side, this is just the IRMAA amount. So it's just, here's the extra you pay if you would be subject to what's called IRMAA. And IRMAA means the income related monthly adjustment amount.
Yes.
Now, Mike, I know you've helped people as we have. There's some exceptions. So if you got a notice, if you enrolled in Medicare, they're looking back at your tax return. Let's say you enroll at 65, they're looking back at your tax return when you turn 63, and you got a notice that you're going to pay this much, but your income's lower now. Tell us about how those exceptions work.
Yeah, so when you actually get this paperwork, and I'll tell you, I think Dana, you've seen it a couple times. It's very confusing. There's about 6 letters that say one thing, but you kind of have to piece it together. But long story short, when you get the notice that says, "Hey, you're going to pay these elevated premiums," there's a little blurb in there. If you disagree with this decision, call us within 10 days. And they'll kind of guide you through this process. But I tell everybody it's very common as you retire. Obviously, you're not making your working wages anymore. That's one of the criteria for appealing this decision. So if you had a work stoppage or a work reduction, even if your income is lower as a business owner or something like that in the year that you're starting Medicare, I urge everybody to fill out it's technically the SSA 44 form. It's a very simple form. There's about 2 lines to fill out. It's a government form that's 8 pages long, but you fill out about 2 lines. And then you just sort of say, yep, my income is now lower due to stopping my retirement. There's a couple of other things that can trigger it, but always worth looking at something there because We can't deny that you made that money in the past, but we can certainly let them know that maybe your income levels currently are not at the same level they were 2 years ago.
Yeah, and then we've had many clients ask, well, if I did a Roth conversion or I realized a capital gain, maybe I sold a real estate investment or a business, is that a reason to ask for an exception? And we're like, unfortunately, no.
No.
There are, yeah, there are 7 reasons. Divorce, unfortunately, is a legitimate reason. But if you just realized extra income 2 years back, you can't just say, oh, sorry, I sold a property that year, I did a Roth conversion, my income's lower now. They don't accept that as a reason.
Right. And one of the things, and I think, even in talking to some of your clients, this obviously comes as a big shock for some that this is even something they contend with, even if they were mildly aware of it. And I always encourage people, it's like, this is a temporary problem, by the way. This is not a permanent problem where you're just going to pay these elevated premiums forever. They're always looking back 2 years. So even if you did do some Roth conversions and things like that, it will potentially be lower, moving forward as your income dips. The other part to look at there is I really encourage people to look at long term. I mean, this is a temporary kick, but maybe, don't derail your financial plan and avoid doing a Roth conversion if long term that makes the most sense for you, just to save a couple years of premiums here, because overall it may not be beneficial to your bottom line.
Yes, and I love that. We do that same analysis, and we've had people say, oh, but I don't want to pay that extra premium. But in the long run, it still made the whole plan look better. So it is a case of running the numbers for each individual person. Speaking of running the numbers, this is a sample timeline of a couple they're turning 62 and 63. These are their ages at year end 2026. And so this is how we run out an estimate of healthcare costs. And so Sam would be retired, and so would Sally, and they're each on a healthcare.gov unsubsidized plan, paying about $1,000 a month. So we see their premiums here inflating, and we typically use 5%. And then what happens here? It starts to go down because Sam turns 65. And when he turns 65, it's near the end of the year. And he enrolls in Medicare. He's got Part B premiums and his Medicare supplement for only about 2 months of the year. And then when he is 66, now his out-of-pocket costs, Medicare supplement and Medicare Part B, actually totaled less than it was pre-65. And we see this quite frequently. Now, one of the questions we'll get is, why are we using such high out-of-pocket costs? If this was a healthy individual, they might not pay that much. Well, we're factoring in things like crowns or chiropractic or massage, things that might fall under out of pocket that we don't typically put in our budget. And so we'd prefer to overestimate this and have that be extra that drops to the bottom line, or build up a buffer so that if 1 year with a more significant healthcare expenses came up, you would have that buffer that had been built up in there. And we see the same for Sally. She turns 65 a year earlier than Sam, and partway through the year, she switches over from her healthcare.gov plan to her supplement, and then we see her Part B premiums. Now, Mike, you said one thing about, those higher Part B premiums aren't forever. And for some people, that is not always the case. What we see, if someone has large IRA balances, now the required distributions aren't starting till later, typically 75, in some cases 73, but those balances can grow significantly, and then the required distributions can put someone permanently in a situation where their modified adjusted gross income is much higher than it was previously. And so from that point on, they may be subject to these extra premiums. And there's sometimes Roth conversions earlier can help reduce that. Taking IRA withdrawals can help that. And sometimes it's just a matter of, you are lucky enough to have enough assets that you will be in this situation. And so all we can do is build it into the budget, and we've already accounted for it. So you don't have to worry that it hasn't been factored in and stress tested.
Yeah, no, and I would say the same thing. Everything's all relative when somebody has that, because it does happen sometimes. I say, you have a good and a bad problem. It's nice that you're successful, and it's just is maybe going to be that way, but everybody's planned for it, so it's good.
Now, let's talk a little bit about Medicare enrollment at 65. So we get this question all the time. It can be quite confusing. I've turned 65. I'm still working and I'm on my company insurance. Do I have to enroll? What do you tell people?
So the answer is sometimes it all depends, but in this instance, generally if you work at a company that has 20 or more employees, you actually don't have to do anything with Medicare. You don't have to take Part A, you don't have to take Part B, you don't have to inform them that you're not enrolling. It's kind of on you to know that you didn't have to, but you don't have to do any of that, right? So that can be an option. Again, we'll talk through this, but if you're contributing to an HSA and you want to continue past 65, even taking Part A will actually not allow you to make that contribution. So that is one time where maybe you don't want to take Part A and continue on with those contributions. So that can make sense. But that's generally how that works for your employer. So you don't want to enroll in Medicare A and B just because you think that that's what you have to do, especially if you work at a larger employer. I've seen this a few times. It's unnecessary premium. Medicare is actually second to your group health plan, so it's really not doing anything other than burning some of your money every month. It's not a good idea.
And then if you have work for an employer, like we're at 16 employees now,
Mhm.
I imagine in a few years we'll have to revamp our health plan because we will be at 20. But then what would you do?
So as it gets to that level where you're below 20, you can technically use your group health plan as a secondary, but generally, if you really evaluate the expense of it, it may not be worth it for you to continue using that as a secondary, and just transitioning into Medicare fully and being independent of the company can make a lot of sense. Again, we just have to evaluate how it works for you. But you would definitely need to take Medicare Parts A and B, because in that instance, Medicare is primary and the group plan is secondary. If you do not take Medicare and you kind of don't do anything, something comes up, the insurer can actually say, you're now in primary position to pay and we'll pay after you. I don't really know how that's going to work for you, because odds are you're going to be picking up the heavy end there, right?
Yep, yep. And then one thing we've encountered a few times is, let's say you're retired at 64, you're on
Mhm.
Cobra, it's going to go 18 months. At 65, you still need to sign up for Medicare, right? Even though you still have Cobra?
Yes, you do. So Cobra, because the reason that you can delay Medicare is it's active employment. So Cobra is not active employment, even if it's a continuation of a large plan. It would become secondary to Medicare. Generally, you're gonna get a notice that says it's gonna cease when you turn 65 anyways. But pretty common now is people
Right.
retire post 65, they get the offer, they're like, especially, hey, I saw I have an IRMAA, like I'm not doing this, I'm gonna do Cobra. Same thing, you don't want to put yourself in a position where you be primary payer. Cobra is expensive. I've never really seen that make sense, but again, we'll just have to look at it as it comes through.
As it comes. And there are some pretty hefty penalties, I know, if you were supposed to sign up for Part A, B, or D, but didn't. And so we're not going to go into those details, but isn't there some type of penalty that's permanent?
So Part B and D penalties are permanent. So if you should have had Part B and you delay it by a year, it's 10% per year. So if you did it 3 years, that's 30% of whatever the premium is. Nobody wants to do that. Part D is a little less daunting. It's 1% per month times the national average. So what that means is, hey, if you had, a year of non-coverage there, it's 12% of about 35-ish dollars right now. That number kind of floats. Again, we just want to make sure that you're not, in that boat. So when you get close to that time, just talk with somebody and make sure that you're doing the right thing for sure.
Yep, absolutely. And that is why we have this next slide of Medicare enrollment month. And
Mhm.
so, um, walk us through this. And I made this slide, so I know, Mike, you asked me what was this 4 months before. There's a special rule if somebody was born on the first of the month. But when do you enroll in Medicare? What are we looking at here?
So if you wanted to enroll in Part A or A and B together, you basically have a 90-day window in advance of the first day of the month that you turn 65. So even if for instance, me, I'm born on the 15th of June. My Medicare is actually going to start on June 1st. So I get to enjoy it as a 64-year-old for 14 days. So people kind of say, oh, it's 90 days in advance of my 65th birthday. No, it's 3 months in advance of the start. And then the fourth month there, as you said, there is a rare occurrence where somebody is born on the first of the month. So if I was born on June 1st, my Medicare would actually start May 1st. It's just how it works. I guess maybe they figured, since everybody else gets to use it for a little while as a 64-year-old, we have to make it fair. But that's where you have that window of that fourth month. So it's still 3 months before you're eligible. It just is 1 month sooner than you would think it is.
Yep. And then how this is an example for someone who is enrolling at 65. But what
Mhm.
about the special enrollment period? You're working till 68, you're working till 70. Then how does this work?
Yep. So good question there, and I get that all the time. So if you exhaust this period that we see at the top, that 7 month period basically where you can enroll, at 65, and this is very common, you're continuing to work, you have creditable coverage through an employer, you don't need Medicare yet. Once you get to that 8th month, so imagine a month after this chart, you kind of have a permanent special election where if you're going to leave employer sponsored coverage, you can disenroll and then trigger your Part B with filling out some forms to verify that you've had creditable coverage to delay it. And then they'll go ahead and just issue that Part B for a date of your choosing. It can be up to 3 months before you want to start it. So as you're planning for retirement, that's where a lot of times we circle in and say, hey, if you want, to be retired in June, this is what we're going to need to do. We'll start filling out paperwork 3 months in advance. And then it just kind of turns on again. You have all the same rights, options, and entitlements as somebody turning 65. So again, get a supplement, no health questions asked. You're not missing out on that. That's just where you want to make sure that it was okay to delay the Medicare.
And, I know I have a note that talks about coverage always starts on the first of the month, and that would be the case whether you're enrolling at 65 or during one of these special enrollment periods. Is that true?
Yes, it always starts on the first. So,
Okay.
timing of that is, hey, if you have insurance through 1 month, even if maybe there's 4 days at the end where you're not really employed, we're just going to start at the next month and we kind of plan for that. But yes, it's anytime you want to pull the plug, you're able to just go to Medicare and that's going to work for you. You just tell us when you want to do it.
Great. Then one of the last things we want to talk about in this post 65 but pre later year phase are HSAs and employer plans. And we touched on this briefly, but actually we probably did touch on it. I think you made it pretty clear, Mike. But if you want to continue pre-tax contributions to your HSA, don't take any part of Medicare, but that's only applicable if you're still working and you are with an employer that has 20 plus employees. Is that sound about right?
Yes, that is correct. And then the only kind of weird thing that you encounter there is they will backdate your Part A by 6 months, and that's from the date of application. So you need to time, when you turn off those contributions if you are looking to retire so that you don't encounter a tax issue that you have to resolve on the back end where there's overlapping periods there. So that's the only thing, sometimes we have to look at a calendar and kind of go back and figure it out. But a lot of people say, hey, I just signed up for Medicare and my Part A signed, 6 months ago. What gives? And it's just how they do it. So you just want to be aware of that one piece.
Yeah, and I believe even if you funded your full HSA at the beginning of the year, you would need to prorate the contributions just for the months that you are eligible to contribute. I've never actually seen anyone audited or dinged for this, but that is technically the rule.
Yep, I'd say it's like, it's that one time. So just make sure you keep everything above board and we'll be good.
Exactly. Um, Then taking a look at longer term trends and how some of these expenses change as you move through what I call the go-go years. So that would be this phase here, and what we're looking at here are total expenditures. This is from JP Morgan's annual Guide to Retirement report. And they study spending from all their banking data for people that have about 1 to 3 million in investable wealth. They looked at 2017 to 2024 to compile this data. And so they said, okay, if we look at when spending is the highest, it's in this 50 to 65 age range. And I would say that's exactly what we see with our clients. Now, if they didn't retire till 65 or late 60s, then maybe this is shifted out a little bit. They go through their go-go years a little bit later, where they're doing their traveling and go-going all over the place. Sometimes it's not going, but it's staying and spending on big remodels or family events, things that they've put off while they were busy working. But then the slow go years generally start I would typically say I see it about the mid 70s. People will tell us they're not spending what we're direct depositing to them. We will ask if they need their planned inflation raise, and they will say, no, we're not spending what you're sending us already. And sometimes their priorities shift to gifting. So you see this blue charity and gifts category goes up out here. And Amy and I know, do our best to try to shift this forward. So we in our retirement modeling, we can see the assets someone's going to have at the tail end. And so it's, well, let's give now if you can afford it and not put your own plan at jeopardy. And so the reason you often see this grow at the end is because people actually realize, oh my gosh, like I have more wealth at the end of retirement than I had when I started retirement. And so they start to increase this charitable and gifting to family. But here's where we see that healthcare line creep up. And what we often tell people is there are some costs we're going to talk about that can be on the tail end, that can be very expensive, that you want to plan for. But as some of these costs rise, we're seeing other areas decline. And so when you look at transportation, we see that food and beverage tends to decline. Entertainment tends to decline. And so that's when we talk about slow go, it's that people are just comfortable staying home and they're not spending as much on going out, but they may be spending more on services. They may be having people come into the home to help more. It might be handyman, just house cleaning, those kinds of things that they were doing themselves that they find that they need. And then we're going to talk now about some of these healthcare expenses that can occur in the later years. So, Stefan, when we think of these later years, I know you help a lot of our clients plan for this expense. What are the different options that someone has for covering these potential costs later?
Yeah, well, thank you, Dana. The when these costs come up, or when we're planning for these potential costs, as we kind of talked about a little bit earlier, from a health insurance solution, right? They're not going to cover the costs for long-term care when you need help, when you need assistance, right? So it's not your health insurance that's going to pay for doctor bills and prescriptions. It's not Medicare, and for some instances that it does, it's a very limited fashion. And we're trying to keep people away from the Medicaid conversation, right? If we do the plans properly, right, we can hopefully avoid having those discussions. So when it comes to paying for care, right, the first thing is that if people do not have a solution in place, it's not a conversation they've had, or some people have chosen to do so, it's what we call self-funding, right? That's when somebody has said that they will bear the cost of potential care in the future themselves. And when they bear that cost, that means that they'll go to their assets that they have to pay for that, whether it's any income streams or potentially any family members that can come along and help cover the cost of care at that point when they need it. Now, for those folks who choose not to self-fund, right? There are insurance options available out there on the market, right? So when we're looking at that, and and I know one of the bullet points that we do have up there for high net worth, high income households who want to retain the risk, I do think that all of these conversations center around a financial plan, having conversations, and having people determine how much risk their plan can support. And I know we'll talk a little bit about the cost of care in the next slide or so. But a lot of times for people who are evaluating whether they're to self-fund or not, more often it's a risk shifting conversation, right? You
Yeah,
know,
and I know we're going to talk about this in a minute, but it's also, even though maybe they could financially retain the risk, we see that people who have insurance are often more likely to get quality care and better care because there can just be that tendency to, no, I'm not going to spend my money.
Yeah, absolutely. And I think there's two components to that, right? There's the financial conversation to have to go along whether or not people choose to self-fund or not. And then I think a bigger part, it's also the behavioral, right? The emotional conversation that folks have in their desire to implement a solution. I think a lot of times, you kind of use this words earlier, Dana, about providing peace of mind, right? A lot
Yes.
of times these conversations, the health insurance conversation, the long-term care and insurance in general, right? It provides that peace of mind, right? So not everyone necessarily needs it financially, but listen, if it makes you sleep better at night, it makes you feel comfortable, it provides a buffer between your assets and the need for care, right? I think it makes sense at the end of the day, right? You do see a lot of those conversations where people will implement something, even though they're necessarily that their financials don't call for it. So I think these are good conversations to have and to continue to have.
Yeah, they are. And when we talk about, people who want to shift the risk or at least a portion of the risk to an insurance company, it used to be when I started in this business, there was only what you called traditional long-term care, where you paid a monthly premium for a pool of benefits. But that has changed a lot. Walk us through the differences between what we would think of as a traditional product and what I know the marketplace generally now refers to as a hybrid long-term care product.
Yeah, absolutely. So the products that most people typically are more familiar with are what you refer to as traditional long-term care, right? The hybrids are a newer generation of solutions that have come up, but both solutions are essentially you're buying a bucket of money that if you ever got sick and needed care, that this is where you can go to, right? And whether or not that bucket covers everything or a portion thereof, right? That's based on how much of this you purchase. But they both function in the same way that here's a place that you can go first to pay for care. Now, the traditional policies that have been around for a long, long time, the argument previously has been that these are the most cost-effective solutions. Now, unfortunately, the way that market has gone, the pricing for these products today have gone up, and those that purchased them in the past, they've also been subject to price increases. So the hybrids versus the traditional, it's more of a preference, in my opinion, in having that conversation to determine what's the best fit. But from a traditional standpoint, just to kind of give the audience here some information on what that looks like, think of it as a pure long-term care, right? You're purchasing it for one purpose only, and that is if you ever need long-term care. The triggering events for both of these products are the same. If you can perform 2 of 6 activities of daily living, that's eating, dressing, bathing, toileting, transferring, and eating, or if you have a cognitive disorder. All right. And usually my little joke is that my wife says I qualify on a daily basis, but she is an underwriter for an insurance company, so maybe I should be concerned, but that's a different conversation. But that's the same triggering events, and then you're eligible to receive your benefits. Now, a traditional policy, there's a couple of things to be aware of this. Because it provides a long-term care only, if you don't use your benefit for long-term care, there's no other benefit that comes with that. There's no life insurance benefit. I did touch on the fact that these policies are not guaranteed from a premium standpoint. So what that means, that an insurance company can come back years in the future and say, hey, based on this policy that we sold in Arizona in 2025, we're losing money on this book of business. We're going to ask for an increase, and they petition the state, right? In those instances, they typically get their increases, or they get those increases over a period of time, right? So the premium that you sign up for may not necessarily be the one that you have in the future. Another thing to be aware of. And the last thing with these traditional policies, which I think is very important, is a traditional policy is a reimbursement style benefit. Now, what does that mean? That once you go through the qualification process, a doctor signs off, the insurance company agrees, a traditional policy will pay out benefits for services provided by a licensed health practitioner or facility, right? So what that means is the reimbursement will only come if these services are provided by a state licensed individual or facility. If you are receiving benefits from friends, family, neighbors, or what I call unskilled care, these traditional policies will not provide benefits. Now, with that being said, right, does a traditional policy work? Absolutely, right? This is part of the conversations, and a lot of times people will say, okay, this does fit me, this does fit my plan. The insurance world, right, they are creative. They've come out with some of these hybrids that do address the concerns that people had directly with the traditional policies, and I'll walk through that. The first thing we talked about is if you don't use it, you lose it, right? Meaning once you combine long-term care and life insurance, the nice thing is there's additional value provided within the financial product. If you don't use it for long-term care while you're alive, the policy has a life insurance benefit, and there's various ways you can dial up and down the benefit. But based on that, if you don't use it for long-term care and you bet on yourself that you will not need it, the money that you invest in the product, there'll be some sort of life insurance benefit that goes to your family, whether it's a return of premium feature or a multiple thereof of the money invested. There would be an insurance, there'd be something left over. The second thing is, since we are combining it with a life insurance component, we can use the word guarantee. So if you sign up for a premium schedule that you're going to pay a certain amount, fixed amount over a period of time, which obviously will help from a planning standpoint, the insurance company will guarantee those benefits. There wouldn't be any situation in the future, as long as premiums are paid on a timely basis, there wouldn't be any situation where the insurance company can come back and ask for more. The way that transaction works, if you uphold your end of the bargain by making your scheduled premiums on a timely manner when they are due, they are obligated to guarantee the benefits that you would receive whenever you might be eligible to receive them, either the long-term care feature or the life insurance benefit. So there's no use it or lose it with those hybrid contracts right there. The last thing, as we kind of progress through the differences here, the hybrids that we like to talk about, they are what's called a cash indemnity style benefit payout. The traditional policies had the reimbursement. The hybrids, the good ones, right, have this indemnity style benefit. What that means is that once you go through the claims process, the insurance company does their diligence and they agree that you're eligible to receive benefits. They will send you a check each month for the amount that you are eligible to receive. They do not care where you receive the care or who provides you that care. So if you are in your home, where most people start their need for care, these policies will pay out those benefits. That care received in your home is typically provided, at least at the onset, from these unskilled caregivers, your friends, your family, your neighbors. The insurance companies for these cash indemnity hybrid products will send you a check and you can spend that as you see fit. So for people who want the most choice, who want to maintain control over where they receive care, and let's face it, I would argue that most people want to stay in their home for as long as possible. These newer solutions allow you to do that and maintain your independence. Now, as you move up the food chain for care to adult daycare, assisted living, full-blown nursing home, once again, these policies still will send you the benefit each month as long as you're eligible to receive it. So the argument is to provide the most value, to provide the most liberal usage of those funds. These hybrid solutions are a conversation that we're having with people on a daily basis to see if they could potentially make it a good fit for what they're trying to accomplish. So, the last thing kind of on that, and I touched on it, you'd be surprised. Some people say, well, there's multiple benefits and you got to pay for two, so it must be more expensive. And that's not necessarily the case. So I think it's a good idea to make yourself aware and have these conversations about what's available out there to help you cover this potential cost for care.
Well, it's also more flexible. I mean, what I hear here is the same as, looking at how the Medicare Advantage plans have progressed and gotten better. These hybrid products that offer long-term care coverage, it sounds like, have also gotten better and better. And that flexibility, to me, can be so key. And, when I look at clients that have gone through that phase where even if they're not in what we might traditionally define as cognitive decline, the decision making still gets more challenging and they can more easily get overwhelmed. Just the ability to have that cash reimbursement basis, I'm probably using the wrong term.
Cash
It's not
indemnity.
reimbursement, cash
Cash indemnity.
indemnity basis, yes. Can be, so just like peace of mind, as you said, okay, one less hoop that I have to jump through now, one less worry of constantly arguing with the insurance company about whether this is covered or not covered. And so that to me, even if it was slightly more expensive, which I know that isn't always the case, but even if it was, I would say I would want to pay for that optionality, easily. That's what I want at that stage of my life.
Yeah, yeah, and I think there's the train of thought that not only is for the person who needs care that makes that process easier, their loved ones, the ones that are helping oversee that care, that makes the
Yep.
process easier for them because there's studies out there that show that if you have a partner, a spouse, a loved one who needs care, and you're the one who's responsible for that care, even at a minor level, right? There's a higher likelihood that you may need care yourself just because of that emotional and physical drain that comes along with it. So I think by
Yep.
having a solution that makes life easier is definitely up for consideration here, and these policies tend to do that for the folks that purchase them.
Yep. Now, let's talk about one more option on here, the continuing care communities, because we see more and more of those where you can move in, while you're relatively healthy. And the idea is that as your care needs progress, it's all right there. But my understanding is that, they don't cover all the costs. And sometimes people are surprised to get bills for additional care once they're in one of these places.
Yeah, yeah. So a continuing care community is essentially the basis behind these. It's somewhere that people can go where they can age in place, right? So once they're in there, they can be with a very limited level of care, or completely autonomous where they're just kind of living out their days. But what the attractiveness of these places is that if you develop the need for care, even minor, everything is in-house, right? So you're not having to pick up and move to another location or move everything there. Everything is taken care of and it's contained in a given area. Now, as you move up the food chain of needing additional care, right, the one thing that does come along with that, Dana, as you indicated, is there is a price for that. So as the care is potentially escalated, the cost to remain in that continuing care facility does escalate as well too. Now, a creative way that people can talk about this is that, okay, well, if I'm in this location and we're determined this is the best fit, what can we do to help offset that potential need for increased costs in the future if we need additional care, right? This is where all these things we just talked about can come into play. The self-funding, have another side fund set up, have IRA money that can be used for that. Or, hey, you know what, if you don't want to bear all the risk yourself, right, a long-term care policy can fit nicely with a continuing care community as your cost of care increases, arguably that you may be able to access your insurance contract to help offset some of those increasing costs. So there are options like that out there. They can be used together or mutually exclusive. But once again, it is another plan, right, that can help offset that cost of care. And once again, at that point in time, it provides that simplicity where there's just one place they can go and they can receive everything they need.
Yeah. And you know what? There's so many. I thought we could get through this content in our first hour, but there's so many more questions I could ask you just about this slide. But for the sake of time, we will move on, and then of course we're going to open it up to Q&A. And so I may have some additional questions there that are going through my mind. But we wanted to look at the costs of long-term care, and so I'm going to pull over. Now, hopefully this is going to work. Yay, it's working. This, just to pull it back for somebody, so for our listeners, watchers, you can see the website that we're at, but we thought we'd pull up 2 zip codes and look at one of the most expensive. It's Greenwich, Connecticut. And take a look at, what are we talking about in terms of costs? And so this is 2024. Stefan, I think you had me slide this over to 2025 so that we're looking at today. And walk us through what we're looking at here on the screen. What are the difference between these 3 things that we're seeing here?
Yeah, absolutely. So on the far right would be kind of the...
Whoops. Where'd it go? There we go.
Yep.
Is it back? Yes, it's back.
Yeah, perfect. Thank you, Dana. On the far right-hand side, in the bottom rightish corner, you'll see 2025 cost of just over $19,000 per month. So in the Greenwich, Connecticut area, which is one of the wealthiest zip codes in the country, right? You can see, and this is inherent on the East Coast to begin with, especially in the Northeast. You're looking at a monthly cost for a nursing home of just shy of $20,000 per month, right? So we're looking at full-blown nursing home coming in and having care. And as we kind of shift over to the left, you talk about community assisted living, where it's kind of just partial care, not full-blown nursing home. We're still at $10,000 per month in the same area. And then the last one to the left, as we move over, this would be the cost of a home health aide coming in for, I believe it's 20 hours per week to kind of assist with the care around the home. Obviously, that would be in a more limited fashion that person requires the care. But once again, you can see how costs can quickly escalate. And, I know we're going to look at another location, but, it does increase fairly rapidly depending on the level of care that you potentially could need.
It does. And, there's a bajillion locations. I want to look at where my parents are, but right now I'll look at Scottsdale. And amazingly enough, it's substantially less than Greenwich, but still, it's something you got to plan for.
Absolutely.
Yep. So for all of our watchers, you could go to this website, plug in your own zip code, and get an estimate. Now, when we are building this into our financial plans, we're often taking what we think of as a worst case scenario and adding up 5 years worth of care and saying on average the stay is about 2.5. Your biggest risk is a longer stay. We'll talk about that in a second. But we try to turn that into a lump sum and say, okay, at the average age of onset, would you have enough to cover at least 5 years of this care? And how would insurance benefits help subsidize that? What's the difference that they would make in your overall plan? Looking at the last thing, I think almost last thing, and then we'll wrap up, is just this, different way of looking at risk. And so, Stefan, as you and I had talked, I put this together in trying to quantify, where the risk lies. Will we all likely need help at home with cooking, cleaning, errands, or yard work? Yes. High probability, probably low severity. But over here, tell us a little bit about this quadrant.
Yeah, so when we're talking about the risk and the likelihood of needing care, I'm not a huge fan of statistics because when we're talking to clients and friends and family and whatnot, everyone says, "Well, I'm going to beat the odds, and this isn't me," right? But I always like to remind people at the end of the day, insurance is there for when things don't go as planned, right? So if we're looking at the left side quadrants, these are what I would refer to as small mistakes, number one and number three, right? We if we have a small mistake, we can usually work our way through it. Number two and number four, right? A higher probability or the high severity where we have a need for care that requires that nursing home, when it requires 24-hour care, when it requires it for an extended period of time, right? These are what I call big mistakes, right? So these are the mistakes that if we plan properly, that we can help avoid or help mitigate the impact that they will have, not only on our financial plan, but on the plan of our loved ones, our partners, and even from a legacy standpoint, our children and the other folks who are important to us that we want to take care of at some point. So I always like to tell people that you know, let's plan to mitigate the impact of having one of these high probability or high severity events. And there's different ways that we can plan to cover that when insurance can be part of that conversation as well too. But once again, right, little mistake, big mistakes. Let's make sure that we're being made aware of where we lie and how we can help mitigate the impact that they may have on ourselves and our loved ones.
Yeah, I think of my grandpa actually when I look at this quadrant four, he passed. My remaining grandparent had passed at 90 over a decade ago now, but he spent I think probably the last 6 to 7 years of his life in a full memory care facility,
Yep.
and so he didn't have insurance. And we were lucky that one of our family members, my mom's one of five children, was in a financial position to be able to help cover that cost, but it was not inexpensive. And,
Yeah.
we had his 90th birthday there. He kind of knew that family was around, but, I wouldn't say he knew who we all were specifically. And so those are the very expensive situations that we do want to make sure that we have a plan for those.
Absolutely. Absolutely.
So wrapping up, and then we're going to open it up to Q&A. I just laughed that I thought we could get through this in an hour. It just, we're talking about possibly breaking this webinar even into 3 webinars because I think we could spend an hour on each individual phase. But creating a holistic plan that includes a timeline of expenses and how that's going to change is invaluable. Of course, we do that. Working with an insurance professional who knows your options, both on the healthcare, Medicare, and on the long-term care. We often get asked questions that we can't answer, and we rely on Mike and Stefan to answer those questions because we can't be experts in all of these things. You can hear how complex and nuanced it can be. We can lay out the overall plan, but then when it comes down to deciding, okay, what type of health insurance is right, what type of long-term care coverage is right, we need experts who understand the nuances and the options that are available. Talk to your benefits department. Stefan, one question I meant to ask you that I forgot was, what about companies that offer long-term care as part of their benefits package? We don't see that too often, but every once in a while we see it. Is that something someone should look at?
Yeah, I'm a big fan of employer provided benefits. Anything that is going to be partially covered or fully covered by employers, it is a good idea to at least take a look at. And once again, right, we talked a little bit about consulting with your insurance professional, someone that has knowledge in the space where they can give you good advice on that. In general, some of these employer provided plans, I would say they're in the infancy of how robust they are. I wouldn't say any of them provide a Cadillac, so to speak, of benefits available. But a lot of times they'd be a good place to start to get your foot in the door. And then, just like any type of employer provided benefit, if there is any gap in your coverage that we can help you identify, right? At that point in time, we can go to the open market and kind of make sure that you're covered at a level that meets what you're trying to accomplish.
That
But,
makes sense. Yeah.
absolutely.
Yeah, and we didn't touch on that either because there's so much, but when we look at, how we estimate the level of coverage, oftentimes we can say, well, you would have X amount of money coming in from, these sources, and then here's the dollar amount per day or pool of benefits that you would need to subsidize that. And so that's how a financial plan can help determine, do you necessarily need a coverage options that are going to cover 100% of the cost? Not necessarily. You may need to subsidize what you have coming in from other sources. And then Mike, we didn't touch on this either because there's been so much, but we know once you have a Medicare plan, every year there's open enrollment. So those open enrollment dates are listed down here below. And it's really important to evaluate your plan choice at that time. Why is that?
Basically, things change whether you're aware of it or not. From year to year, it's like you get your annual notice of change. I joke with people, it makes sense to, treat your notice of change as more than just a coaster for your coffee table. Actually look at it, still make sure that prescriptions are covered. If it's an Advantage plan, that your doctors are still in a network. And then really just compare it to, hey, is there a more efficient plan, sometimes even with the same insurer, that I might be able to enroll in for next year that helps my bottom line a little bit rather than just continuing to use the old version. So always just good
Yep.
things to check in with people and make sure it's working the best.
I know you've helped several of our clients evaluate their plans and ended up saving them, sometimes, I think the largest was up to $2,000 a year just by what was covered and what wasn't covered. So
Yep.
it can save you money too. We didn't touch on that aspect, but
Yeah,
sometimes changing
absolutely.
plans. Yep. Yep. Well, opening it up to Q&A, thank you so much, Stefan and Mike, for, all these questions. I know we typically get a lot of audience questions. Amy is going to help us field those, but you do have a question box where you can submit questions, and it looks like there's a lot of questions that have come in. So Amy, any that you want to start with?
I've been trying to answer some as we go, but I definitely did not get to them all. So, one question that came in, I don't know the answer to this, but someone asked if the recording shows the Q&A. Do you know, Dana? I don't think it does.
It does not. No,
Okay.
because we want you to all have privacy. We can see the name that you registered with, but we wouldn't make those Q and A's public. So we only can see them. We would never make those public.
Thank you. I didn't think they were on there. So I'm going to go back to the beginning. A lot of the questions did get answered throughout, which was great, but let me see. I was starting to make a list as we went through. So, Mike, this one is probably directed towards you. Someone asked if it's advisable to hire a broker to secure an ACA plan.
Yes, it's absolutely advisable. There's actually no fee for using, a broker to look at these plans and to help you enroll in one. You can do it yourself. You can get help from the marketplace itself. But again, if you were to work with someone like me that would guide you through the process, it's a commodity product. There's no savings if you do it yourself or vice versa. So yes, you never pay someone like me directly for those services. So I would say absolutely seek help.
Yep. Somebody else asked if you needed earned income to contribute to an HSA. I can answer that one as no. I did not answer that. You just need an HSA eligible plan. Let's see. So there's a lot of questions coming in now. I can try to get some of those since they are still on.
I see
Um,
one I can answer real quickly, and it was around whether the out-of-pocket costs we were showing were monthly or annual. Those were annual costs, and so it's just a rough estimate of over the course of a year what might we expect someone to pay in co-pays, doctor's visits, non-covered needs, dental, those kinds of things.
Someone else asked, if basically if you are traveling between states, do you need a Medigap plan?
I would say that it depends. Again, it goes back to the conversation of you can solve for that problem with either an Advantage plan or obviously with a Medigap plan. We just have to see if it makes sense by evaluating your needs in both locations and if the solution that's provided is efficient for your purposes.
Another question for you, Mike, was would it be correct to assume that pre-65 retirees that go over the cliff would pay similar premiums if they, paid full price for ACA compared to private market insurance?
It's kind of tough to say because we would have to define what private market insurance really is. But yes, I mean, simply put, if you're over that 400%, subsidy cliff, you're basically just paying retail cost for the health plan from the health insurance company itself with no additional premium. So, whether you make right at 401% of the federal poverty limit or 4 million times the federal poverty limit, the cost would be the same at that point.
Another question on HSA, someone asked, can you only use the HSA with the bronze plan or all plans?
Good question. So, yeah, going into next year, bronze level plans will qualify you to make the contributions. They're eligible plans. If it's not specifically a bronze plan, it would just have to be designated as an eligible high deductible health plan, which can vary from state to state.
Speaking of state to state, this one is a more specific question, but it says if you are generally healthy without significant pre-existing conditions, would you recommend underwriting with insurers to harvest cost savings? For example, in Tennessee, we have access to Farm Bureau high deductible plans that offer significant premium cost savings and access to HSA accounts.
So basically put, I mean, I'm a big fan of if you have anything at your disposal that you can throw into a pile of options and it meets your needs and it gets it done at a more affordable price point that improves your bottom line, absolutely consider it. You just want to make sure that you're actually aware of what you're paying for, how it works, and making sure that it truly covers your needs. But yes, if there's a really good option, let's look at it every time. Yeah.
Yep. More on the Medicare front. Oh, go ahead, Dana.
Yeah, I saw one. Can you confirm that IRMAA also applies when using Medicare Advantage? Yes. So if you have a Medicare Advantage plan, your basic Medicare Part B premium, I believe, is included. But if you have IRMAA, you will still pay the difference. Is that correct, Mike?
Yep. So you still have to pay your Part B and D IRMAA charge, whether you're in traditional with a drug plan or Advantage plan. It's, I joke with people, there's no outrunning the government. They're going to ask you to pay that premium no matter what. It just is what it is.
And I'm clipping through the slides really fast to get back to the beginning. Somebody wanted the contact information, so I'm going to leave that up. So those who want that information can have it and can shoot anybody an email that they would like.
Another Medicare question was about what supplemental plans are typically recommended.
So more and more, I mean, especially because there used to be a Plan F, which you can still get as an applicant. You just had to be technically eligible for Medicare prior to 2020. That is in there. I would say more the kind of modern plans that I would look at are maybe a Plan G or a Plan N. Again, it just dictates situationally what it is. But I mean, of all the letter plans, I would say it's like if you're looking at Plan K and L and M and you're obsessing about that, there's, if you really look at the details, maybe it's not quite as beneficial to have plans like that. But yeah, just kind of F, G, and N, and then rarely N or rarely F, I should say, anymore, just because of the premium to benefit cost ratio.
Thanks, Mike. Stefan, I'll send one. Oh, go ahead, Dana.
I'm trying to pick them off while you're answering one. I'm trying to find the next one so we can maybe switch off. Can your HSA be used to pay for insurance marketplace premiums? The answer is no. It can cover COBRA. It can cover Part B, but it cannot cover your marketplace premiums or your Medicare supplement premiums.
Correct.
Yeah.
Yeah, going back and
Amy?
forth is a good idea, Dana, because every time I find a new one, then I get lost. So, um,
Yeah.
Stefan, this one is for you. Are traditional long-term care policies less widely available today with only a few carriers offering it?
They are. They are. Unfortunately, the way that that marketplace went for the traditional policies, in the past, you had a lot of companies that were offered those types of products, but now there's only a handful that still participate in the space, and most of the long-term care solutions being offered are the hybrids, and almost every insurance company out there does offer some sort of hybrid long-term care solution.
Great.
I'm seeing one, if one wishes to self-insure for long-term care, how do you generally account for that? And so we will look, and this kind of coincides with another question I had, which was, at what age do you typically assume care needs start? In the planning model, we typically assume early 80s. So let's say, and it can vary if there's a married couple and an age gap between them. But we might say, okay, care needs could be as early as 80 for the oldest spouse. And so what's our pool of assets available and how many years of care would it cover? And if that is not enough, then what are our options to fill in the gap? And the other, consideration is an example we have right now, a client who her husband passed away several years ago. She ended up moving in with her son. And, we wouldn't call it medical care needs that she has, but kind of that family has been providing care and they were able to have a mother-in-law or mother of suite available for her. She's only 73 and they just let us know that she will be needing to move into an assisted living facility. So even though we use 80 as an onset, on an average onset, as Stefan said, averages are hard because, there's always these cases where something may happen at a much younger age that we just didn't anticipate.
I have another one for you, Stefan. After 100 days in a long-term care facility, if you go back to the hospital, does the 100 days reset for Medicare to cover?
So it depends on the gap that's elapsed in between kind of the stays and how much time has passed and whether it can be determined to be part of the original event or this is a new subsequent event where enough time has elapsed where Medicare would consider it a new qualifying event. So it is possible, right? But there's no guarantees that if the guidelines have not been followed or it can be deemed to be a one continuous event, then you may be stuck with just the first 100 days being covered with the co-insurance for the latter part of that.
Got it.
I like it. Someone's
Mike,
trying to game the system. Someone's trying to game the system. I like it.
In the insurance marketplace, how much does the broker get paid by the insurance company? Now, I know there's no difference in cost to the consumer, so I don't know how you want to answer that.
I would say it all depends. It's typically like a per member per month kind of fee structure. It's low. I mean, I don't think anybody that's doing marketplace help like myself is in danger of buying a yacht or anything like that. We're going to be okay. But yeah,
I know you
as
work hard and answer lots of questions.
we
And I,
do. We do.
yeah,
Yeah. And I would just say, to look at that, it's like I tell everybody, whether it's Medicare or ACA or something like that, if you enroll directly with a company, they have people that make, a salary to work there that are going to help you one time. If you work with me, it's like I work with you and it's similar. It's like, so I'm an external distribution channel versus an internal distribution channel, but somebody will be compensated to help you whether you do it yourself or not.
yeah. Amy, do you have any more?
There's a lot more. I think a lot of them were answered. This one is specific. If we have TRICARE, which will shift to TRICARE for life at 65, will we have to get Medicare? How does that or does it not impact whether we should select Advantage or Medigap?
So great question, and it actually hits on a couple of different things. So by itself, you will need to get Medicare Parts A and B to transition into TRICARE for life. The good news there is your TRICARE premium will become zero. You then pay Medicare directly for your Part B premiums. And TRICARE itself has drug coverage built into it that's pretty fantastic. And then basically, TRICARE for life is a really robust supplement. It just works in secondary position to Medicare. Again, it's, if somebody says you need a Medicare supplement and you have TRICARE for life, you don't do it. It doesn't make sense. They do have Advantage plans now that pair with that, where maybe you could potentially rebate your Part B premium. Again, if you wanted to use your TRICARE as sort of like a catch-all for some of the co-pays for that. So it's actually designed, everybody's a little bit different there, but yeah, it's definitely worth evaluating. But do not forget to enroll in Medicare if you're on TRICARE and approaching 65. That's not going to work at all for you.
Stefan, I see this one. Is there a place to find and compare long-term care insurance and hybrid care options and costs?
So there's no centralized location that you can go online and do this type of research yourself. The suggestion is to work with an insurance professional who has access to the various products and companies that offer these. And a lot of times the pricing on these is going to be based on a number of factors, right? It's going to be your age, it's going to be your health, and it could be how much benefit that you're looking for to kind of supplement any other assets that you have. So, to use Mike's word early, it depends. But that's why we encourage anyone on the call here today to work with the folks at Sensible Money, to work with the professionals out there that are well versed in this space, and they can help you navigate and compare and contrast the various options and solutions that are available out there.
We love it depends. It's always the right answer. That's the only right answer there always is. Another interesting question I saw was, do you ever create a long-term care bucket portfolio with its own asset allocation and time segmentation? Um, you know, I I would say I have never done that, but it's part of what we do with the overall plan. I mean, we are big believers in simplicity, so we try not to have multiple different like accounts for different purposes. Instead, we try to create one comprehensive retirement plan, and we think of, your overall portfolio as one big bucket that is there to fund the things that we think might happen, and also be there as an available resource for the things that we could never predict. I don't know, Dana, if you have a different perspective on that, but I have never seen a separate long-term care, bucket created within a retirement portfolio.
I would say, our buckets are in a spreadsheet format, right? Like we know there's this amount of assets that could be used for that purpose, but we don't bucket them into the individual accounts. It just adds a whole layer of complexity to trying to manage the investments and trying to rebalance and trying to manage taxes. And so I like your answer, Amy. We try to keep it simple, but in the spreadsheet planning, right, in the financial planning modeling, you can say, well, we have this potential contingent cost of up to X, and will there be sufficient assets to cover it? Because we don't know the timing, and that makes it really hard to create a specific asset allocation bucket for it.
Any other ones that you see, Dana? I think most of the other ones we have answered.
Oh, it's hard for me to see the full question, this particular interface that were used here. So oftentimes I can see the first part of the question, but not the second.
If you click on it, I think it will open it up, but then when you go back, it like loses your place in the
Yep,
where
I've
you were.
noticed that.
Yeah.
So I'm seeing one. Let me see if I can click on it. For pre-65 coverage, could you expand on the option of part ownership in a company that provides health insurance? Mike?
Yes. So there's a couple of third-party benefit administrators. So if you currently have work insurance, if you flip over your card, you may notice there's a name on there that says, please remit claims to, and there will be a company listed. So they actually have designed ERISA-based health plans that give you access to commercial networks, that you agree to become a fractional owner of the company, and you may have some duties there, like answering an occasional survey or something like that, that give you access to the group health plan, which you cannot do as an individual, or as even if you have a spouse and you have a company together, you can't have a group health plan based on just being married. So it's kind of a newer, unique option for some folks. It fits the need for some. It's not definitely for everybody, but you know, if you're curious, I'm absolutely happy to discuss it in detail.
I'm seeing one that I believe is from a client of ours. Are there any circumstances that allow contributions while enrolled in Medicare? The answer is no. So that's an easy one to answer.
Don't do it.
One that came in somewhat recently, it says, I have employee spouse medical coverage through a large employer and plan to retire post 65 and enroll in Medicare at that time. My spouse will require COBRA or ACA coverage. Is spouse COBRA extension from 18 to 36 months a possibility in this scenario?
Yes,
I believe that one is yes. Yep.
Yep, absolutely. So that's part of it. You know, if you're thinking again, even a couple years out, hey, what's going to happen? Worth a conversation, and we just kind of, you know, line up what's possible there. But yeah, you know, that's something that I contend with a lot. Happy to help.
Clicking through.
Well, I think, unless you see any more, Amy, that might be as many as we're going to be able to get to today. It's such an engaged audience. It's amazing to me how everybody stays on the whole time. We've had a couple hundred people, I believe, on this webinar, and so many of you stay till the end and ask so many questions, and that's what helps us know what kind of answers you're looking for. It helps us improve the content every year that we do it. So I see some applause coming in. Thank you for those of you who use the little emojis. Amy, any last questions that you see that we really need to get to?
I think we did cover most of them. If there's any we missed, feel free to reach out and let us know.
Yep. Thank you, everybody. Amy, Stefan, Mike, thank you so much. And visit our website for our next webinar. It's coming up in the fall, and it's on tax planning for retirement, and it'll be all refreshed content with the new tax laws. We're going to take a look at it in a fresh way. We hope to see you all there. Bye, everybody.
Thank you.